Okay, so welcome to the seventh webinar that we've had in the Foundations in Critical Care webinar series. This webinar series is really focused on improving bedside care of critically ill patients, regardless of resource setting. We have panelists from all over the globe so that we can crowdsource together solutions for problems that exist when challenges that exist when we try to manage our patients. So my name is Anna Maria Crawford, and also with us is Dr. Andrea Komisky. We are your hosts of this series. Dr. Komisky is an emergency medicine physician with a specialty expertise in critical care medicine. She's part of the core faculty within the Foundations of Critical Care webinar series. We also have Dr. Rachel Kimani. She's an anesthesiologist in Nairobi, Kenya. She's an expert and consultant in medical education and training, quality improvement, surgical system strengthening, and she's one of the primary organizers of this series. Dr. Nicole Arkin is an anesthesiologist and ICU physician at Stanford. She's an expert in medical education and training. She has a master's degree in teaching, and Dr. Arkin currently serves as the co-director of the ICU fellowship program at Stanford University. She also leads the critical care medicine clerkship for our medical students here at Stanford. Mr. Eddie Owino is an experienced ICU nurse. He has expertise that span both the high resource and low resource practice settings. He's passionate about bringing safe and high quality care to rural Kenya. Mr. Owino currently works at Stanford, but often returns to Kenya to improve care there as well. Very excited to have my friend, Dr. Elizabeth Okbali Wasor. She's another renowned anesthesiologist. She's a professor and chief consultant in anesthesiology, pain medicine, and obstetric anesthetics. And she works at Ahmadu Bello University Teaching Hospital in Zaria, Nigeria. Dr. Leah Franco is a neurologist and critical care specialist. She's also at Stanford. And has won multiple teaching awards and other awards for her humanitarian work. And our real expert in renal is Dr. Pedram Fatehi. He is the director of critical care nephrology at Stanford and also the medical education director for the Department of Medicine at Stanford University. So with that, I want to just walk us through some quick housekeeping. We want to make sure that this is a respectful and safe learning environment. If you disagree with something that is said or something that is put into the chat box, please do so with kindness and respect. We do have the question and answer function at the bottom of the screen. So if you have any questions, feel free to use that. We want to build community and network. This is a webinar that has people from all over the globe, all different types of patient care providers. Make sure you introduce yourself in the chat and meet others from across the globe. This session is being recorded. Your attendance is your consent to be recorded, and all of the session materials will be hosted online on the Learning Resource Center. You can use closed captions. They are available at the bottom of your screen. This may help if you're a non-native English speaker. We will all try to speak slowly, of course, but the closed captioning may help you understand what is said a little more clearly. The Learning Resource Center is an online platform that hosts all of our materials and all of our courses. It is free and open access to anyone. And Dr. Komisky will put the link to the Learning Resource Center in the chat box for you, and we will post it a few times just so people don't miss it. Anyone who attends this session and who registered for this session will automatically receive an email with instructions on how to claim your CME or CPD. Again, you must be registered for the session in order to receive that email. We want to give special thanks to the Department of Anesthesiology, Perioperative, and Pain Medicine for sponsoring the CME that comes with this series. And with that, let's go ahead and get started with Dr. Arkin.
Good morning, everyone. Welcome to our case-based discussion on renal disease in ICU patients. Today, we'll analyze a real-world scenario and discuss the pathophysiology, diagnosis, and management of acute kidney injury in critically ill patients. This presentation is designed for both physicians and nurses working at the bedside anywhere across the globe. So we'll jump into our learning objectives. By the end of this webinar, we want you ideally to be able to recognize the risk factors and causes of renal disease in ICU patients, understand the diagnostic criteria and biomarkers for AKI, evaluate treatment strategies, including fluid management, dialysis, and pharmacologic considerations, apply evidence-based management strategies in complex ICU cases, and utilize key resources. We'll provide infographics as well as literature so you have something to fall back on when you're making decisions in the future. We'll use a case-based approach to apply these objectives to real-world patient scenarios, and we'll highlight practical tools and key references. So this is our patient, Mr. Kenneth Nkosi. Patient is 62-year-old gentleman, Kenneth, admitted to the ICU with septic shock secondary to pneumonia. He's got hypertension, type 2 diabetes, CKD stage 3, and benign prostatic hypertrophy. His current status, he's intubated on mechanical ventilation, on norepinephrine vasopressor, noradrenaline, for blood pressure support, with rising serum creatinine levels. Let's explore how this patient's condition affects renal function and what our next steps should be.
So, how do you classify chronic renal disease? Now,
So we'll give the audience just a few minutes to answer that question, Lizzie, and see if they have some ideas in the chat.
Okay.
You have about 30 seconds.
Okay, so here in this slide, we have the stages of chronic kidney disease. This is the KDIGO prognosis of CKD by GFR and albuminuria categories. So what we have here is G1, G2, G3, G3A, G3B, G4, and G5. And on the other side, we have the persistent albuminuria categories, the description and the ranges. And we have A1, A2, A3. And this helps us to know that mild kidney disease is green, and that is the one that we will see because it is low risk. If there are no other markers of kidney disease and no chronic kidney disease. The ones that are in yellow are for moderately increased risk. When there is moderately increased risk, that is what you see is basically the classes G3A and A2 of the albuminuria. For the orange is the high risk. And the ones you see in orange shows that there is severely increased albuminuria, that is class A3, where you have more than 300 milligrams per gram and greater than 30 milligrams per millimole. These are the ones that are in the G2, G3B, G4, and G5. And this shows that there is very high risk of chronic kidney disease. By the way, GFR is the different categories that describes the ranges for the chronic kidney disease.
Okay, sorry for that delay. And for Mr. Kenneth Nkosi, what additional risk factors for renal dysfunction does Kenneth have in this acute setting? We'll give some few seconds for responses, then I will go through them. I can see the answers, type 2, race, sepsis, hypertension, and all that is correct. So that to sum that up, Mr. Nkosi has several additional risk factors for renal dysfunction in addition to um, his chronic disease that is already existing. Hypertension is one of them. He has a high blood pressure at baseline. Septic shock can lead to hypoperfusion of the kidneys and worsening renal function. Patients with septic shock are at higher risk of acute kidney injury. Mr. Nkosi is on noradrenaline infusion, which also increases the risk of renal hypoperfusion and worsening renal function. Fluid shift is a common thing in critically ill patients, so this fluid shift may compromise renal perfusion. In addition, Mr. Nkosi is likely exposed to multiple medication, including sedative and antibiotic, which can be nephrotoxic, and this can worsen the renal function, and abnormal renal function can alter medication pharmacodynamics. So all the answers were correct. And finally, patient with benign prostatic hypertrophy or other anatomical obstructive pathologies can also have post-renal obstructive process that further impairs renal function. So it is important to follow the urine output closely in this patient to ensure urine is being produced by the kidneys, but also to ensure there's no blockage by the enlarged prostate.
Thank you, Eddie. Yeah, I think what you're describing is what a lot of people think about when they consider kidney dysfunction, and that is the pre-renal, intrarenal, and post-renal causes. So thank you so much for covering those.
So next, what we can discuss is the pathophysiology of acute kidney injury and critical illness and renal disease, especially in critically ill patients. Acute kidney injury results from a complex interplay of hemodynamics, inflammatory, and nephrotoxic insults. In ICU patients, renal injury results from multiple overlapping factors, including the hemodynamic instability. You get this very overwhelming inflammatory state. And then you also have several medication effects that we use very commonly in the ICU. This complexity highlights overall the difficulty with managing renal dysfunction in critically ill patients. And we will discuss how each of these impact renal disease in the ICU patient. In summary, our patient will most likely develop acute kidney injury in addition to his chronic kidney disease. And therefore, he's at a high risk for requiring potentially dialysis, worsening overall chronic kidney disease and function, and that could include decompensation to renal failure. So next, we're going to explore each of these 4 factors in much greater detail.
Let's talk about the epidemiology of renal disease or acute kidney injury. When we think about acute kidney injury, it can happen, usually we see it at the hospital, but we can also see it in the community. In high-income countries, it's most likely to be seen in the hospital where we're actually checking. We can see that a hospital-acquired AKI or the kidney injury is much higher here as a hospital-acquired in the higher bar. And when we divide that between adults and kids, the proportion is about the same. 22 to 24% of the adults and kids that are hospitalized can have an acute kidney injury, and 32% are in those adults that are in the ICU. So it's much more common there.
This is great data to understand, Leah. Thank you. I have a question. A lot of this data is from high-income countries, but I want to ask Dr. Lizzie, Mr. Eddie, Leah, you are from Ecuador. You've also worked in a lower resource setting than Stanford. Is acute kidney injury common in those settings as well? in your experience?
It is. From my experience in Ecuador, we see it common in the hospitalized patients, but we are less reactive to them when it's a minimal increase. In here, we check frequently the creatinine in the labs every day. But in depending on how the patient was back in Ecuador, we wouldn't check every day. It would be a little bit more spaced out, or we just say, "Oh, there's a reason for it," and we'll wait to check again.
Yeah, we check too many labs, I think, in this high resource setting.
Yes.
Thank you for sharing your experience.
I can talk about this next slide. This is, you see kind of on the bottom axis here, the perfusion pressure to the end organ, and then on the y-axis along the left, you see the glomerular filtration rate. So the basic idea here is that there's a normal range, which is rather wide with respect to steady perfusion pressure. And the kidney has a bunch of mechanisms to protect itself when the blood pressure goes low or high. These protective autoregulatory mechanisms will keep the GFR and the pressure inside the glomerulus steady so that the GFR is steady and urine production generally is steady as well. So this graph might look familiar to you from a physiology class earlier in your training. In fact, it's the same autoregulatory graph that you see in the brain as well. Interestingly, there are two lines here. The solid line is what most people would say that the typical normal range, where the perfusion pressure, the mean pressure running anywhere from about 50 to 150 or 60 to 160 is the range of mean arterial pressure in which the GFR is kept steady. Now, the dotted red line is a scenario in which a patient has chronic hypertension and that autoregulatory range has shifted to the right, as you can see. So the important concept here is that the steady mean arterial pressure that would be considered ideal for this patient will kind of depend on what the long-standing mean arterial pressure is, and a patient with hypertension probably has higher mean pressure requirements for steady GFR.
Thank you, Dr. Fetahi, our local nephrology expert here in critical care. We're really excited to have you as a panelist. I want to ask you a clarifying question about this slide. When I was in training for anesthesia, we did learn that we want to keep the mean arterial pressure between 50 to 150 for the consideration of this autoregulation. But then as I've gone through my career, I've heard more commonly to keep the mean arterial pressure between 60 and 160 for a normal person without baseline hypertension. Do you think that the 60 to 160 is a good range to target for mean arterial pressure in someone without hypertension?
Oh, that's a great question. We can ask Dr. Franco her opinion on this as well, because as I said, this concept of autoregulation is similar in the brain. In fact, every end organ has the tendency for a reflexive autoregulatory mechanism in the arterioles. I think, most of us, and I'm interested to know your own practice, Dr. Crawford, about keeping a mean arterial pressure above 65 when you have a patient in shock. I would say that the take-home message really is if you have a sense and other clues clinically that the patient or known history that the patient has chronically had high blood pressure that has not been well controlled, that you typically would maybe target a slightly higher blood pressure. Whether the number is 60 or 65 or 50 or 55, I think it's hard to say. Dr. Franco, do you have an opinion on this?
Yeah, I think that the other way around will apply more. If they're chronically hypertensive, in our patient population, we've seen that the patients that have acute, like a brain injury, it's much better the outcomes if you keep the mean arterial pressure on the higher side that they're used to. If they're used to living with a systolic of 180 or 200, it's not good for them if you're going to drop them to 140 if they have a brain bleed, for example. But it is harder to see to think about it when the patient has normal blood pressure. I think that in that case, we fall into the guidelines of keeping it lower, especially for the brain. But I don't think we need to be as strict of, as you said, of the 55 or 60 in certain populations.
Thank you. So it sounds like the concept of autoregulation exists in every patient, but the exact range is definitely dependent upon the patient, their history, and their current disease process. Thank you
Yeah,
both for sharing your opinions on that.
yeah, I would agree with that.
Yeah.
This next slide highlights some of the key features at the maybe microscopic level or with respect to, again, some of the autoregulatory mechanisms. What you see on the right are the arterioles around the glomerulus. And again, taking you back to histology and early in your training, maybe you'll remember that the kidney has this interesting anatomy of two arterioles in series, the efferent and afferent arterioles, or afferent and efferent arterioles. And again, that anatomy allows the blood vessels to those two blood vessels to vasodilate and vasoconstrict as need be to try and keep pressure at the glomerulus steady throughout. And again, we already talked about this concept of autoregulation, but the take home here again is that in a patient who has deranged physiology, such as somebody who has shock or has been placed on pressors, those autoregulatory mechanisms are not going to work as they normally would. And so normal perfusion pressure at the glomerular level is going to be altered and not normal, predisposing to worsening kidney injury. And then, of course, having a case in which a patient has sepsis or systemic inflammatory response, in which the endothelium and the capillaries are more leaky than they normally would be, that shift in fluid would be another common reason why normal perfusion and volume in the blood vessels are not going to be feeding the kidney as they normally would. We're getting way back and again back into histology, and you're looking here at microscopic tissue of glomeruli and tubules. Some of the key points here are some of the basic science around the specific different types of injury that can be seen in the kidney. I think one of the things I will emphasize is that we often and appropriately think of low blood flow as being an important cause of kidney injury because the kidney and then each nephron does depend on steady blood flow and blood pressure at the glomerulus, as we just discussed with respect to autoregulation. And when that blood flow and blood pressure drops below a certain level, below the map that we discussed, certainly that would be a reason for ischemic acute tubular necrosis, or ATN. Aside from that, though, there are other ways in which tubular cells can become injured and necrotic, and that would be called toxic ATN. In this case, that toxicity could be from an inflammatory environment, as could be seen in sepsis. You can think of this also as a situation in which a patient gets pancreatitis and ends up with ARDS from a diffuse systemic inflammatory response. You can think of the kidney and the tubular cells in the nephrons as being similarly predisposed to inflammatory injury. So the concept of sepsis-associated AKI and tubular necrosis is related to that. Again, we're getting now subcellular, very deep, that you'll remember that the tubules are energy intense. They use lots of ATP and lots of oxygen for ATP production, and that ATP is used to reabsorb sodium, especially in the proximal tubule. And so if there's low blood flow or injury to those tubular cells, and normal mitochondrial function doesn't happen as it should, that can quickly lead to tubular injury, and be a reason for tubular necrosis, and otherwise. There's mention of cortical nephrons here, and that's just to compare it to juxtaglomerular nephrons, which are spread along the cortex or near the medulla, and have to do with concentrating ability of the urine in the setting of low flow. I don't know that clinically the cortical and juxtamedullary nephrons probably aren't things that we think about too much.
This is excellent. Thank you so much for taking us back to the kind of cellular basics of what happens. I think a lot of us see sepsis very often in intensive care unit or critically ill patients, and we think a lot about the vasodilation and low blood pressure and therefore low blood flow that happens to the kidney. But it's a good reminder to know that you're also having these other insults to the kidney, such as inflammation and oxidative stress. So thank you for reminding us of that.
Sure. Another key thing that comes up often in the ICU, and as was mentioned by Mr. Eddy a moment ago, that patients who are in the ICU and are critically ill often are exposed to various medications that can either cause injury or worsen injury. There certainly is a reason why most of us in our day-to-day practice would not give a non-steroidal anti-inflammatory or NSAID to a patient before we see what their labs are. Even when we see what their labs are, certainly in a patient who's in shock, we would avoid NSAIDs. Also, ACE or ARB medications as they relate to blood pressure management. Certainly a patient who's in shock, we probably would not be thinking about giving them ACE or ARB anyway, because their blood pressure is already low. But the underlying message here is that those two medications in particular, NSAIDs and ACE or ARBs, are classic for causing inhibition of normal autoregulatory mechanisms that the kidney has. So again, I'll take you back to physiology from early in your training, maybe, in which you'll remember that the afferent and efferent arteriole will open up or close down to try and keep the glomerular pressure in the middle steady, and NSAIDs will cause vasoconstriction of the incoming afferent arteriole, and ACE and ARB medications will cause vasodilation of the outgoing efferent arteriole. Both of those factors, both of those influences of medications will cause a drop in the pressure at the glomerular level, and therefore inhibit normal autoregulation and normal self-protection of the kidney. So those medications together, and certainly in a low flow or low blood pressure state, would be reason for worsened acute kidney injury. The other ones that you see, again, diuretics are not generally considered intrinsically toxic, that they themselves don't necessarily cause kidney injury, but the injury comes if the diuretics are used to the point in which the volume status goes from volume overload to actually volume underload, or hypovolemia and overdiuresis, and that would be a reason to have a kidney injury or to worsen kidney injury. The top two bullet points, antibiotics, certainly aminoglycosides and amphotericin would be notorious medications that have direct toxicity, and then vancomycin has over time been implicated with various mechanisms of causing tubular injury or interstitial injury. The second bullet point, contrast agents, or I'll specify iodinated contrast agents as we would use in CT or in angiography with an interventional angiography suite. The modern agents often are not necessarily considered as nephrotoxic as they used to be, although they can cause injury. I think I would just highlight, though, that most nephrologists would probably say if you need a CT with contrast or you need an angiography study with iodinated contrast, to make a definitive diagnosis and to make definitive treatment and management decisions that would actually save so-called life or limb of the patient, that's probably a risk worth taking. So the contrast agent one, I would just put maybe in quotes as something to potentially avoid.
That is an excellent review, and these are very practical questions and things to consider when you have a patient with acute kidney injury. I have a couple follow-up questions, if you don't mind. Some of these are really contraindicated when you have acute kidney injury, but some of the medications, for example, the antibiotics, we will actually just change the dose. We do this often when we have a bacterial infection that is only sensitive, for example, to vancomycin. But some of the other ones we would really try to avoid altogether. With the CT contrast, the iodine contrast, does hydration play a role in that? If we give the patient extra fluids, does that decrease the risk that patients will have worsening kidney injury from the contrast agents?
Yeah, that's probably the most common technique people would employ to try and preempt and prevent contrast-induced nephropathy or contrast-associated nephropathy. I think even stepping back from contrast, most kidney toxins will have a worse effect if the patient is hypovolemic. And again, this has to do with a lot of the autoregulatory factors we talked about a moment ago. So certainly if you're not worried about volume overload or heart failure or pulmonary edema and profound hypoxemia, if you're able to have a little more kind of fluid in the tank, so to speak, and a more euvolemic patient rather than hypovolemic, that would be considered the most protective option. Historically, people thought maybe you could give Mucomist or bicarb, but probably volume repletion is the most reliable. Yeah, that's a good point, Dr. Croft.
Thank you so much for that review. That's the really practical stuff that we do every day in the ICU. So appreciate that.
All right, so let's summarize again our patient-specific risk factors, as well as the ICU or critical illness specific risk factors. So we think about these in two different compartments. What is our patient bringing to the table in terms of their risks? And then what is happening to them in terms of their critical illness? And what is their risk of renal injury based on kind of their pathophysiologic state? So our patient brings with him older age, greater than 60, a baseline history of chronic CKD, diabetes, which predisposes to endothelial damage, hypertension, which can both accelerate vascular disease, but then also, as we learned, kind of shifts that autoregulation curve. And so maybe a MAP of 65 isn't adequate for him. And then he also brings with him a history of heart failure and liver disease, which can predispose to fluid overload and congestion. In terms of his ICU-specific risk factors, he's in septic shock in a state of inflammation and hypoperfusion. He's mechanically ventilated with increased intrathoracic pressure that basically can reduce renal perfusion. He's on vasopressors, which will further constrict the renal arterioles. Major surgery or trauma, ischemia, reperfusion injury, nephrotoxic medications, contrast, aminoglycosides or NSAIDs, and then prolonged ICU stay, which can cause cumulative stress on the kidneys. Okay, so how many risk factors does Kenneth have for AKI? I'm going to give you about 30 seconds to count, and you can put your numbers in the chat.
I would just point out that I think this description of Mr. Nkosi is not very uncommon for the patients that we see that present to our medical intensive care units. A lot of patients come to us in advanced age with high blood pressure diabetes or some of these other things that you've mentioned, and then they get their critical illness on top of that background. So it's pretty common scenario, I think.
Nice. All right. Well, we definitely have, I would say probably the mean is correct. So in terms of, I counted 7 risk factors. Mr. Nkosi is 60 or older than 60, has hypertension, diabetes, CKD, septic shock, vasopressors, and mechanical ventilation. ICU patients are highly susceptible to AKI due to multi-system dysfunction. So early recognition of these risk factors and an understanding of their underlying pathophysiology allows for early intervention with fluid resuscitation and vasopressor adjustments. We can use renal protective strategies such as avoiding nephrotoxins and optimizing perfusion. And then the third piece, which we'll get to shortly, is timely dialysis initiation when it's indicated.
So next, we're going to give you about 1 minute to type in the chat how you diagnose an acute kidney injury in your practice.
I think this is an interesting question because we've talked about the chronic kidney disease, but now we're talking about acute kidney injury. They can occur at the same time, but we see a lot of acute kidney injury even in patients that don't have chronic kidney disease in the intensive care unit or in critically ill patients. So it's a good thing to recognize it so you know how to treat it and prevent further decompensation.
And I'll say, just finishing my renal elective, one of the things that they noted was that they usually can recognize an AKI sooner than most of the consultants who are contacting the renal colleagues. And so recognition is something that I think is very important and that they stressed to me as a learner on their service. So definitely something to take into consideration. So everyone's put in good answers, and the most common thing that I'm seeing written is creatinine clearance and urine output, which is phenomenal because with the kidney disease improving global health outcomes, or the KDIGO, it's an international organization that developed evidence-based clinical practice guidelines for kidney disease, and so it's very useful for us to use pragmatically. The KDIGO definition and staging system is the most common and recent preferred definition for AKI. In the context of AKI, the criteria are based on serum creatinine levels, as most people have alluded to, and the urine output as well. So the criteria for the KDIGO differ from earlier with the rifle criteria that was previously used, in that the KDIGO only utilizes changes in serum creatinine and urine output, not changes in GFR for staging, with, however, the exception of children under the age of 18 years old. So that's something to note, for whom the acute decrease in the eGFR to less than 35 was included in the criteria to stage 3 AKI. In practice, though, the staging of AKI is usually less clinically relevant and utilized more for research studies. More commonly, and I also will say this based on my clinical practice, physicians note the change in creatinine from baseline. And then, as Dr. Crawford and many others have alluded to, we get labs very frequently. And so we check that every single day and monitor the levels and where it's plateauing, is it continuing to increase? And so, in the role of that, we also take into consideration the urine output. So is the patient becoming anuric, so no urine output, oliguric, less urine output, or are they non-oliguric, they have normal urine output, or are they becoming more robust with their urinary excretion? It is important, however, to note and recognize the worse the AKI, but either criteria, creatinine to GFR ratio, or urine output, the poorer the prognosis. So like I said, early recognition and management is certainly very important in this overall for patients.
Thank you so much, Dr. Komisky. And I think building upon what you were saying, and then also what Dr. Franco mentioned earlier, in many settings, that are less resourced than Stanford. I mean, Stanford has almost too many resources, I would say, sometimes, but when you're in a setting where you don't check labs every day, I think it really is important to follow urine output in critically ill patients. And once you see that urine output go down, really start to look for the reasons. Is it because of a decrease in blood pressure and pre-renal perfusion? Is there an obstruction that needs to happen? Do they have for example, a Foley or urinary catheter? And is it running? Is it blocked? Sometimes there's a blockage in the catheter itself. And then if those things are corrected, then it might be a good idea to send for that serum creatinine. Unfortunately, many of our colleagues face challenges in that labs may not be available. Labs may cost money for the patient and their family. And also the results of the labs may not come back in time. So I think understanding the risk factors for acute kidney injury and making sure you can control everything that is available to you, including blood pressure and perfusion, including volume status, and including the avoidance of those nephrotoxic agents, is really the things that we can control in almost any setting.
I'm struggling with my audio a little bit. I'm not sure if you guys can still hear me.
We hear you well. Thank you, Eddie.
Okay, thank you. So the clinical signs and symptoms of kidney injury, we have the low urine output, hypertension, and edema. Patient with AKI may present with symptoms and signs resulting directly from diminished kidney function. These include edema, hypertension, and/or decreased urine output. However, many patients with early or mild AKI have no clinical symptoms, and increase in creatinine is detected incidentally by the frequent laboratory testing that we do, as most of my colleagues have mentioned. Hypertension deserves special attention as a presenting symptoms, and it is less commonly the cause of AKI in ICU patients. So AKI in ICU often develop as patients suffer from hypotension, which can lead to ischemia and acute tubular necrosis. And we do see this a lot, especially prior for the patient to arriving in ICU. They will be having blood pressure in the 70s, 80s, they're giving boluses. And then by the time they arrive in ICU needing pressor, sometimes it's like we are late to the game.
Now, but the diagnostics of acute kidney injury, once you've identified your patient has an acute kidney injury, it's always good to go back and revisit the history of the patient and their physical exam. It might help you determine what the etiology of their kidney injury is. Then you may go up and think about what are the labs that I need to include to be able to evaluate my patient in a stepwise manner. Probably, for example, a urinalysis that is available in most settings. It's a urine dipstick, and you may include microscopy evaluations. They want to think about maybe is there a possibility of certain infections, or maybe a urine sediment analysis. The lab that you would check usually are serum creatinine, the electrolytes. It's good to always have some glucose there, and of course our BUN. We'll check the calcium to evaluate for hypercalcemia. A complete blood count with white blood cells. You want to think about anemia. Some patients with chronic kidney disease may start to see some anemia or thrombocytopenia or eosinophilia to think about other reasons. A renal ultrasound can also be considered to rule out hydronephrosis. It can occur in any obstructive process. It could be either from a kidney stone, a malignancy, maybe an infection, and prostate enlargement, which is the most common thing I think that we probably see. Now that there's a lot more accessibility with POCUS, with the point of care ultrasound, we can evaluate at bedside the hydronephrosis and even some bladder distension while we are assessing for the inferior vena cava or the volume status in our patient. Now, in sepsis and septic shock, Is decreased urine output always a sign of hypovolemia? I'll give you a second to answer. What do you think?
Anyone who is a good test taker might guess the answer by the way the question is phrased.
Yeah.
Thank you, Dr. Franco. What is the answer?
So the answer is no. You all are correct. Urine output can be an indicator of euvolemia in critically ill patients, and oliguria and anuria are more common and associated with renal dysfunction or acute kidney injury. Urine output should be monitored in all of our patients, but other assessment may be needed for volume status in acutely ill patients. For example, your MAP, your mean arterial pressure, you can check for capillary refill time. We do that frequently in kids and babies, and sometimes we forget to do that in adults, but it can help. You want to check the mucous membranes, the skin turgor. Ideally, if you do it in the chest or in the hands, in the forearm. The IBC with the POCUS, and do a classical passive leg raise response where you increase the leg, you raise the legs of the patient and check the response with the blood pressure.
Okay, so unfortunately, despite our best efforts, Kenneth is getting worse. So as we've just learned from our KDIGO criteria, I say KDIGO, but I doubt that's correct. But he develops oliguria, so urine output less than 0.3 mils per kg per hour. He has worsening creatinine that has more than doubled in 48 hours. And his blood pressure remains low despite fluid resuscitation and norepinephrine or noradrenaline. So now he meets criteria for stage 3 AKI. What are our next management steps? Let's examine some real-world treatment algorithms.
Yeah, so for this patient, the first step to do is to do a volume status assessment. So the basics, we start from the basics, do a history and physical examination. And from your history and physical examination, find out, does it suggest that the patient has a volume depletion? So if it is a yes, it means that you should repeat volume and repeat the creatinine assessment, and also find out, after repeating the assessment, is creatinine returning to the baseline? Or on the other hand, if it is a no, then you go to the next step in the algorithm. But for the yes side, if the creatinine is returning to the baseline, you have to monitor for continued recovery. If the creatinine is not back to the baseline by the time of discharge, you have to follow up the patient as an outpatient. On the other hand, if it is a no, that means the history, physical examination, maybe it suggests sepsis or septic shock or hypotension or nephrotoxic exposure. So you now have to consider other things, whether could it be a yes or could it be a no. So step 2 is to assess the perfusion and presence of nephrotoxins. So you go to check the volume, and you also repeat the serum creatinine assessment. Is creatinine returning to the baseline? No. If it is not returning to the baseline, you have to check the history, a physical examination again. Does it suggest that there's sign of septic shock, hypotension, or some nephrotoxic exposure, like nephrotoxic medications that may actually contribute to acute kidney shutdown. So if it is a yes, then you have to evaluate the patient for acute tubular necrosis. If your answer is a no, you have to complete the initial laboratory testing and obtain kidney imaging to exclude an obstruction. Is there a radiographic evidence of obstruction? That means you have to assess the X-ray findings and find out what are the outcomes. Is it a yes or is it a no? So from this, you will know whatever your answer is. Yeah, so that's it.
Okay, excuse me. So acute ATN or acute tubular necrosis has been mentioned several times. So I'm going to give you about 15 seconds to type your answers in the chat. What is acute tubular necrosis? And I'm only giving you 15 seconds so that we can get through all the materials on time. So I'll go ahead and start to describe acute tubular necrosis as the most common type of acute kidney injury in hospitalized patients. It's associated with high risks of morbidity and mortality. It occurs when the tubular cells are damaged or destroyed, and that decreases the renal function. The most common cause is reduced blood flow and oxygen to the kidneys. If you remember the nephron and glomerulus as described earlier. Untreated prerenal azotemia can lead to acute tubular necrosis. Other common causes include dehydration or hypovolemia, hemorrhage, vomiting, diarrhea, burns, heart failure, sepsis, and other forms of shock. And certain medications, as mentioned earlier, the non-steroidal anti-inflammatory drugs and the ACE inhibitors. Both pre-renal disease and ATN can occur in a variety of settings. Pre-renal disease may result from true volume depletion and hypotension with selective kidney injury or ischemia, while ATN is principally due to all the causes of severe prerenal disease, particularly hypotension. The urinalysis can be normal or near normal in pre-renal disease. Hyaline casts may be seen, but they're not an abnormal finding. In comparison, the classic urinalysis in ATN, you may see muddy brown granular epithelial casts. The absence of these, however, does not exclude ATN. So ATN occurs when the tubular cells are damaged. Both prerenal disease and postrenal disease can lead to the destruction of those cells. And you can see here on the pictures on the bottom left that they have these muddy casts that are seen in the urinalysis. So ATN can result from ICU-related complications. You can also have nephrotoxic injury, as previously discussed, and some patients may actually have a genetic susceptibility to those cellular damage. Dr. Comiskey, or sorry, Dr. Lizzie, do you want to talk about the step 3 to rule out obstruction for acute kidney injury?
Yeah. So you have to continue in your assessment of the patient. And the step 3 is to rule out if there is obstruction. So you might have done some assessment, the initial assessment and laboratory testing, and then you have obtained imaging to exclude obstruction. And when you assess the slides, maybe the CT scan or you do a radiography, you have to check, is there radiographic evidence of obstruction? If it is a yes, then you have to address the obstruction. If it is a no, then you have to perform subsequent evaluation. And this should be guided by the clinical presentation of the patient and the results of the initial laboratory tests. So if the acute kidney injury still remains unexplained, you have to proceed to do further evaluation. And this is determined by the patient's clinical presentation, the severity of the disease, and the rate of further decline. So if you do the analysis of the serum creatinine, if it is only mildly elevated. That is, his estimated GFR is 45 to 60 mils per minute and per 1.73 meters squared, then the patient remains means the patient will remains stable. But if the creatinine is moderately elevated or severely elevated, then, or if it continues to increase, then you have to proceed to further find out what is the real cause of the problem, and you might have to proceed to do a kidney biopsy. But if the patient is like mildly elevated serum creatinine, you just continue to monitor the patient as an outpatient and continue to assess the patient as he progresses or continues to improve.
Thank you, Dr. Lizzie. I think kidney biopsy is usually done as an outpatient, but it's definitely something that we should be considering. Okay, so how is Mr. Nkosi doing now?
Unfortunately, Mr. Nkosi continues to get worse. So what do we do in this situation? What are the indications for urgent dialysis? So despite the rehydration, antibiotic for septic shock, blood pressure support with vasoactive infusion, Mr. Nkosi's renal function and urine output do not improve. So the ICU team gives 2 escalating doses of loop diuretics. The commonly used one is Lasix or furosemide and or Bumex. He continued to be anuric. He has an increasing requirement for oxygen on the mechanical ventilator with FiO2 increasing from 60 to 100% with a PEEP of 12. So this urgent indication for dialysis will include, in this case, the fluid overload, such as with pulmonary edema, which can be seen on X-ray, severe life-threatening hyperkalemia refractory to medical management, uremic complications such as altered mental status, pericarditis, severe acidosis despite medical management, and removal of some toxins or medication.
So a common mnemonic to remember it is AEIOU, or the vowels of the alphabet. And we see this very common, I think, in our intensive care unit, where the patient stops making urine because of their acute kidney injury, and then they have a subsequent pulmonary edema and increased oxygen requirement. So that's a very good review. Thank you.
Yeah, so once your patient has this possible requirement of dialysis, we think about, as mentioned, the AEIOU. I usually go down the checklist whether he meets either of these requirements, without forgetting the medicines that you can dialyze, any drugs or toxins that you might be able to dialyze. So when you think about those, is usually the substances that are not highly bound to protein and that are water soluble. Those are easier to dialyze. So, for example, the ones that we can see the most is INH, or isopropyl alcohol 2. I've seen ethylene glycol. You may see that, and that should be dialyzed as soon as possible. Salicylates, theophylline, uremia. You can think about these mnemonic. I stumbled, but in my head, I don't. If English is not your primary language, sometimes these mnemonics can be tough. So for me, my mnemonics go in Spanish if I use them. So find whatever works for you, or keep a picture of it on the phone for emergencies. You can follow these through, like barbiturates, lithium, ethylene glycol, as mentioned, that I've seen, and these are less likely. I haven't seen the dabigatran and the valproex, and usually for the dabigatran is, for example, if they have uncontrolled bleed, you want to take that away. The ones that you cannot remove with dialysis is the digoxin. That's really important because it's highly used in many places. Tricyclics, the phenytoin, your seizure patients is one of the oldest drugs, so you'll see some of these patients may overtake your phenytoin. The glycoside, the beta blockers, which except the atenolol, if they overtake it. The benzodiazepines, macrolides and quinolones, and warfarin. For those, you just got to wait it out.
So, one thing we wanted to point out was helpful resources that you can use after this session to keep learning. And so, one of them is the World Federation of Societies of Anesthesiologists, who create free and open access educational resources. One useful resource is the Anesthesia Tutorial of the Week. And so, there's a very useful review of renal replacement therapy for critically ill patients. Please follow the QR code link to access this great review and check out other free reviews of high yield topics, many of which we've covered in these sessions over the year.
So I'm just going to ask everybody to take a moment and think, at this moment now, the patient has gotten worse, to think about starting dialysis and the details of that dialysis, such as which equipment you would use, the type of dialysis specifically, and the kind of the modality or the frequency.
I think we should also maybe clarify that dialysis is also sometimes referred to as renal replacement therapy. I think another good consideration for our participants is what resources are available in their setting. We don't all have the same access to the different types of renal replacement therapy.
Yeah, renal replacement therapy, or RRT as it's called, is, I completely agree, Dr. Crawford, a really helpful way to think about it. In the biggest sense of the word, even kidney transplant is considered a form of renal replacement therapy. The ones listed on the slide here in front of us include the most common types, which would be intermittent hemodialysis. The schedule for intermittent typically is 3 times a week or roughly every other day for dialysis, and that might typically run for 3 or 4 hours. Number 2 that's listed is the continuous renal replacement therapy or continuous dialytic therapy, and that's one that is in our setting, probably in most settings, almost done exclusively in the intensive care unit and generally reserved for patients who have hemodynamic instability and are often on pressors. There might be a few other reasons related to volume shift or brain edema that might warrant continuous therapy. And then the last one is a hybrid, which is kind of something in between intermittent, so not continuous 24 hours a day, but not intermittent, only a few hours every other day. So hybrid would be something in between, and that's sometimes referred to as SLED, or sustained low efficiency dialysis. Another term you might see is PERT, or prolonged intermittent renal replacement therapy. Let's see. The next slide here shows the different mechanisms that can be used with the filter that's set up. The mechanism on the left is hemofiltration, which uses the concept of convection, which basically means there's a filter and there's increased hydrostatic pressure applied on one side of the filter and less on the other, such that much of the fluid and the amount of fluid is dependent on the pressure difference across that membrane. Much of that fluid is pushed through that semi-permeable membrane, and whatever solutes are in that solution get pushed through as well. Typically, that includes what are called middle molecules or larger molecules. In contrast to hemofiltration or convection on the left, in contrast to that would be on the right, the mechanism of hemodialysis, which is good old-fashioned diffusion, in which solutes and everything will just move across the semi-permeable membrane in the middle down their concentration gradient. And optimizing that concentration gradient is key. So you can imagine, for example, in hemodialysis, actually the next slide shows this, I think, pretty well if we want to go to that one. On the top slide, you can see that the patient is getting, sorry. On the top slide, the patient is getting ultrafiltration or hemofiltration, and this is the concept of convection that I mentioned. So everything is being pushed through, the fluid is being pushed through the membrane as well as the solutes. And you can think of the solutes as including things like BUN and other uremic toxins, potassium, hydrogen ion or acid, and in some cases, other toxic substances such as lithium or uric acid, other things that might want to be dialyzed. In contrast, on the bottom, you can see that things are moving down their concentration gradient by diffusion. And again, I'll just highlight the fact that middle molecules, which are shown in red, are not diffusing across as well in the setting of diffusion or hemodialysis. So the decision about which mechanism or which modality one would use does depend somewhat on what toxin exactly it is that one is trying to clear. So that might be a reason. But for most cases of kind of uremia and uremic toxin clearance, in general, hemofiltration and hemodialysis are both used often interchangeably. And in some cases, the setup can have actually hemodiafiltration where both things are happening at once. I think maybe I'll move through this because it might be boring everybody to death unless you're a nephrologist.
It's not, I don't think it's boring at all. And I think it's definitely something we need to understand. I think it's very resource dependent, you know, whether you have a machine that can do both of these things with the filter availability. But I do think it's really important, you know, at Stanford, we're very high resource. So we actually have people like you that are experts in dialysis. And then we also have specialized nurses that run our dialysis machines. But in many places, even some in which I've worked, you actually have to write your own orders for dialysis. And so I think it's good to understand the mechanisms behind them.
Yeah, excellent. That's a
Yeah.
great point, Dr. Crawford. In fact, it reminds me one point I wanted to make about this, that even in a high resource place like the US, during times in the pandemic, and you probably remember this, that there were runs on CRT machines and dialysis machines, and literally the
Right.
people who needed dialysis and continuous dialysis in the ICU could not get them.
Right.
And we might have been on some of these committees together, sat and planned for contingencies in which we would actually place emergent peritoneal dialysis
Yeah.
catheters to
Yeah.
try and do basically that would be diffusion. It's a form of diffusion peritoneal dialysis, which you know can certainly be done and was done in this country actually within the last few years.
Thank you so much. I think that's a great perspective to share. Dr. Leah Franco?
Yeah, so now you start, Kenneth, on renal replacement therapy using intermittent hemodialysis, or we call IHD. And you decide to place a dialysis catheter on Mr. Knossi. So what type of cath does he need, and where should you place the cath?
Maybe we'll give the participants 15 seconds to answer.
Yeah.
Are you seeing any good answers in the chat?
Yeah, I can see. Good. You have some people talking about IJ, femoral vein. Yeah, good. So these are really good answers, and that's what that we have highlighted here. So the procedure should be done by somebody that has experience in using large bore access catheters, and each side has its own pros and cons. So you may choose to put it in the IJ, the internal jugular, the subclavian, or the femoral. I usually think about, I always default to do the right IJ is easier, straightforward path that you go straight to the superior vena cava on the right side because that's where it's easier. We usually always use ultrasound to guide us, and there's lower complications there. The problem, the cons when you are using the IJ is that of course you can have pneumothorax compared to the other ones. It's slow, but it can happen. And you can puncture the carotid. This is more if you're not using ultrasound, but I know a lot of you might be really good at doing it without ultrasound. Uh, the problem also is that, of course, what I think is that there's this theoretical potential risk of increased intracranial pressure. So if you have a patient that has higher intracranial pressure, like a big brain bleed or a tumor, and you are affecting the IJ, it may affect the pressure in the skull. Not much evidence there, but we always try to avoid that procedure in those patients in the IJ. The problem also is that if you can't use the right IJ, you have to use the left IJ. Then it's kind of you have to make a loop, and the procedure can get a little bit more complicated. And it's also next to all the airway devices. The next one that you can use is the subclavian. That one that has a really low rates of infection and is more comfortable for patients. But you gotta be good at subclavians. You don't really need ultrasound for this. So I bet most of you might default to that one. The problem, of course, as you may know, is there's a higher risk of the central venous stenosis. So you can have longer complications on this side compared to the IJ. And it can affect in the future when you want to put, if the patient still is renal failure and it's permanent dialysis, it can affect with the creation of fistulas. And of course, the pneumothorax. That one is a way higher when you're thinking about subclavians, and it happens really often. The femoral access, that's a nice one to do, I think, because it's easier. You are less complications immediately with the procedure. And there's more freedom accessing other devices. It's kind of more comfortable for the patient and it's faster to place. But there's the increased risk of complications in the anatomical location. Especially if the patient's on the lower BMI, they're very thin. They're higher risk of hematoma, especially retroperitoneal hematomas, or even in that area. We've seen that frequently in our patients. And there's risk of DVT. And also the patient can move. And, we are also very good. We try to make our patients move as soon as possible so they can leave the ICU.
Thank you so much.
So I can talk a little bit here about the prescription for dialysis. I think along the lines of what was already mentioned, that this sort of prescription and order for hemodialysis or dialytic therapy is really best done by an experienced provider, somebody who feels comfortable doing it. The key variables or factors that one would consider when ordering dialysis is the type of dialyzer or the semi-permeable membrane that I mentioned earlier, the duration, the blood flow, the dialysate flow actually, which isn't listed here, but also would be, and then the dialysate composition. Maybe I'll take a moment just to talk a little more about the dialysate composition. As you might imagine, high potassium, when we say AEIOU, the E that is most commonly concerning for us, the electrolyte most commonly concerning for us is potassium, because hyperkalemia can lead to arrhythmia and other complications. And so very frequently we have to decide how much potassium to have in the dialysate to try and correct that hyperkalemia. I would say in general, as a renal fellow, I learned the rule of thumb was the rule of 7, which is basically that whatever the patient's potassium level is in the blood, in the serum, the potassium bath should add to that number, should make 7. So if the potassium in the patient's blood is 5, you should be on a 2 potassium bath. If the patient's potassium is 6, you should be on a 1 potassium bath. Again, the idea being to lowering the potassium. I should also mention that rapid changes in potassium are potentially thought to be arrhythmogenic in some cases and cause arrhythmia. And so some people use a gradual decrease in potassium baths over the course of a few hours. The duration of the session that I mentioned a moment ago, it's listed as 4 hours or more. And certainly for most patients who need dialytic clearance, will get between 3 and 4 hours a few times a week for kind of a total weekly clearance of solutes that would be required. Because in some cases, patients have uremia and they've actually developed uremia over a long period of time. There is this concept of disequilibrium syndrome. And this is a notion that the body and specifically the brain and the cells in the brain have adjusted to this hypertonic extracellular fluid because of the high urea and other uremic toxins. And so doing a full long dialytic treatment with normal clearance and normal settings of dialysis to get good or effective clearance can actually lead to overly rapid clearance of urea and cause volume shifts into the brain that can cause this disequilibrium syndrome, including cerebral edema, seizures, and even brain herniation in really severe cases. So again, that should be done with caution and in the hands of somebody who's experienced. But the duration and the blood flow of the dialysis treatment are really dependent on the case. The other variables listed here include dialysis temperature. As you can see, various temperatures actually can be set. Sometimes people use cooler dialysate as a way to effectively cause vasoconstriction, and almost as though it's a pressor. So a patient who's hypotensive might be given cooled dialysate as a way to try and avoid worsening hypotension. That comes, unfortunately, at the cost of some discomfort for the patient, like shivering and just being very cold. I skipped over bicarbonate, but I should have also mentioned, along with potassium, bicarbonate is another important factor because acidemia is the A in AEIOU, and that's an important factor to keep in mind. But again, would not be overcorrected or overly rapidly corrected in chronic cases. And then the last variable listed on the table here at the bottom of the slide is the anticoagulant that one would use. So low molecular weight heparin or unfractionated heparin may be used. Unfractionated heparin IV given during the treatment is probably the most common for hemodialysis. Citrate, which is a regional anticoagulant, and I'll remind you, I guess I've been assigned all the topics that take us back to our first year of medical school, but you'll remember that citrate binds calcium in the coagulation cascade, and in so doing, effectively blocks the normal coagulation cascade. And then the patient can be given calcium back or ionized calcium back systemically to try and reverse that anticoagulation. So citrate is considered a regional anticoagulation, most frequently used for continuous renal replacement therapy. I will highlight that patients who have a brain bleed or a GI bleed or other risk of hemorrhage may be run with hemodialysis or dialytic therapy without any anticoagulation, although that obviously will come with some risk of clotting of the dialysis circuit. Maybe I'll pause there in the interest of time.
Thank you so much. That's really amazing review and explanation. In my experience, the hospitals or settings in which I've worked where we did not have access to wonderful nephrology doctors like yourself, and we were writing our own dialysis orders, we had standardized order sheets where you could tick a box on the different types of concentrations of potassium or bicarbonate, the flow, the duration, the temperature, etc. So it might be useful for people that are trying to get dialysis access in their institutions to develop a prescription form for dialysis that would be useful to help providers make these decisions. But those are excellent reviews. Thank you so much. Is it true or false? Continuous renal replacement therapy is superior to intermittent hemodialysis for patient outcomes in the setting of acute renal injury. And I'll give you guys just about 15 seconds to answer this question. And then I'm going to pick on Dr. Pedram again to help us with the answer to this one. Okay, what is your answer, do you think, Pedram?
Yeah, I mean, nobody has ever done a study that shows that continuous renal replacement therapy is better than intermittent. I think the thing that often will come up is that we typically employ continuous renal replacement therapy in patients who are in shock and often on pressors. And so what that means is that continuous renal replacement therapy you can think of as just a very slow, inefficient form of intermittent dialysis that takes 24 hours to do the work of 2 days of intermittent dialysis. So what that means is that clearance is very slow, but the blood flow is much lower, and therefore the blood pressure doesn't drop as much during continuous therapy. So if continuous therapy is not available in your institution and only intermittent hemodialysis is available, what that typically means is that one should be prepared to have pressors and use pressors during that treatment, basically. And then I'll highlight a point that I made earlier about a hybrid therapy called slow, low efficiency dialysis, where the blood flow and the clearance is slower and less efficient, basically, than intermittent hemodialysis, but a little bit faster than continuous. And so there are some hybrid in between options, but nobody has ever proven that one of these is better than the other.
Okay, now you start, Kenneth, on renal replacement therapy using the IHD. Dialysis begin, and 5 minutes into the session, blood pressure drops to 70/30, and his heart rate increases to 125. That is trying to compensate for the low blood pressure. What do we do?
This is a very, very common scenario in critically ill patients that although they need emergent dialysis, they are hypotensive during it.
So these are the common things we do to troubleshoot this. We reduce or discontinue the ultrafiltration completely, increase the frequency of treatment by decreasing UF, increase the duration of treatment. That's where like the CRE, continuous renal replacement treatment goes for 24 hours or more days. Increase duration of treatment, vasopressor support. Very typically, these patients are on midodrine, which they're given an hour before the start of IHD, or there's always like Levophed or adrenaline ordered ready to go before the dialysis starts. Cool temperature dialysis may mitigate hypertension. Fluids boluses, which our dialysis nurses are good at starting. They have protocol that they follow. They do that, and sometimes albumin boluses, and then we can increase the distillate calcium.
Wonderful. Thank you. Yeah, these are things that we employ very often. I'll just mention one thing about the fluids. We often are trying to remove fluid from the patients because they've not been making urine, and perhaps they have pulmonary edema or some other complication of fluid overload. And in that case, we would probably opt to use albumin rather than a crystalloid type fluid for that patient. How is Mr. Nkosi?
Well done, everyone. Mr. Kenneth Nkosi begins to improve over the next 3 days. He now makes a small amount of urine at 0.8 mLs per kilogram per hour. His vasopressor requirements have decreased, and his noradrenaline drip has been stopped. His sedation has been weaned, and he passed his spontaneous breathing trial on the mechanical ventilator. You have decided to extubate him today and are hoping for a good recovery. Congratulations to you and your team for this excellent care.
Thank
Well
you so
done, everyone.
Thank you. Thank you so much. So I am going to stop screen sharing, and I just want to say thank you so, so much to all these amazing panelists. This was an excellent discussion. I'm going to see if we have anything in the Q&A. We have just a couple more minutes. Most of us are on service and have to run to the intensive care unit, so we don't have a ton of time, but we'll try to get to a couple questions. So the first one is, at times the nephrologists are not keen on obstetrics of challenging the kidney with furosemide. How would you manage this? So has anybody had experience where you're trying to challenge the kidneys? And what does that mean to challenge the kidneys with furosemide?
I'm
So
happy to take a swing at
oh,
that one, or
okay,
if
I
you
was
want,
going to
or if
say,
you want the audience to take a swing,
we
yeah.
often will challenge the kidneys with furosemide when we have some oliguria and urea. But what is your experience on obstetric patients?
Well, I guess maybe the question is for fear that hypovolemia in a pregnant patient more than in a non-pregnant patient might lead to placental insufficiency and a poor blood flow to the placenta. So certainly that's an appropriate concern. We're getting into really, I would say, the fine points of trying to assess what a patient's volume status is and how confident you are in that volume status. I would say as a rule of thumb, if the blood pressure, the mean arterial pressure and systolic pressure are high, then and the patient has edema, you can feel pretty good that the patient has high volume status and that volume is effective arterial volume or effective circulating volume. And that if you're trying to try a so-called furosemide stress test, that it would be acceptable to do that. It certainly becomes questionable, obstetrics or not, if a patient has, maybe they have edema, but their blood pressure is low, giving that person a diuretic certainly would maybe be questionable for fear that you would actually make them in worsened pre-renal or worsened hypoperfusive state. Hopefully that helps.
I think that's helpful. Yes, thank you so much. Okay, I think we'll end there. I just really, again, want to thank all our amazing panelists, Dr. Nicole Arkin, Dr. Andrea Comiskey, Dr. Leah Franco, Pedram Fetahi, Mr. Eddie Owino, one of our amazing ICU nurses, and of course, our esteemed professor, Dr. Lizzie Mossor. I'm Anna Crawford. We'll see you next month. And remember that the materials from this, all the slides, all the notes, and some of the key resources are available on the Learning Resource Center. That link should be in the chat for you to reference. And with that, we'll see you next month. Thank you so much to everyone. We'll see you next time.
Thanks. Bye.
Thanks, everyone. See you in June.